Hello everyone, welcome all. We're just waiting a couple of minutes for people to join. If you could remember to turn your camera and microphones off, please, that would be really great. And Carrie and Kim will introduce themselves in a minute and take us through this webinar, Finding Nemo. Thank you, welcome all.
Thanks very much, Sally. Kim, do you want to come on camera? A warm welcome to everybody, and we'll have our first slide, please, Rebecca. This session today is from the Impact Research Group, and we're going to be talking about Finding Nemo, how to lead and facilitate culture change. My name is Carrie Jackson. I'm Associate Professor for Practice Transformation at UEA, and my colleague Kim is with me. Kim, would you like to introduce yourself?
Yes, good morning. I'm Kim Manley and I'm Professor for Practice Development at the Impact Research Group at UEA.
And we're joined by Sally Hardy, Professor Sally Hardy from our team, who's very kindly going to facilitate the chat, so you'll see a bit more from Sally later on. So we go to our first slide then, please, Rebecca. I just ask everybody just to make sure that their microphones are on mute, please, and that your cameras are turned off. So a warm welcome. This webinar today builds on our first webinar series where we introduced the Venus model for person-centered sustainable transformation. And we have done a baseline facilitation workshop, which you can see on our YouTube channel. So today what we're going to be doing is revisiting the concept of integrated facilitation and its role in both systems and workforce transformation, and sharing our collective experiences and reflections of facilitating in practice, exploring the principles that underpin the Venus model. And we're going to illustrate the sorts of facilitation strategies that we've used in projects through a series of case studies, looking at how you facilitate increasing complexity at micro, meso and macro levels of the health and social care system. And we're going to flag some of the challenges about what doesn't work. And then at the end, we're going to identify the grey areas of facilitation that we feel need further research and development. So we're going to draw on a number of case studies, which we'll come to in just a tick. So the next slide, please, Rebecca. So we start, first of all, by being really clear about what we mean by integrated facilitation. And this is really about taking a holistic approach, an integrated approach to facilitating learning, development, research, innovation and improvement, using the workplace as the main resource for delivery of person-centered, safe and effective care. Next slide, please. And just a reminder that facilitation is one of the key stems of the Venus model and an part of the integrated skill set that we're advocating that systems leaders need for successful person-centered sustainable transformation for the future, along with leadership, culture change, improvement and innovation, and practice development principles, which are about how we authentically engage with stakeholders and citizens through a process of collaboration, inclusion and participation. Next slide, please. So I'm going to hand over to Kim, who's going to talk you through the next series of slides. Thanks, Kim.
Thank you, Carrie. The essential enablers for finding Nemo, a metaphor for achieving person-centered, safe and effective cultures across integrated systems, were identified in a big health education project in Kent, Surrey and Sussex, which identified the workforce enablers necessary to achieve whole systems integrated working. And these three enablers, sorry, I'm on the previous slide, Rebecca, sorry. These three enablers were clinical systems leadership, skilled facilitation using the workplace as the main resource, and also facilitating integrated frameworks around people and citizens, competence, capability frameworks around careers, around the citizen rather than around the profession. And this facilitation skill set is integral to the clinical systems leadership role. The next slide shows, Rebecca, please. The next slide shows further research that was undertaken from the project I just mentioned, and this involved developing multi-professional integrated facilitation standards using a Delphi study, and this involved working with experts in practice development, work-based learning, practice-based inquiry to develop consensus about the key skills underpinning integrated facilitation and the theoretical influences that explain how it's achieved. So whilst other standards previously existed, they tended to be uniprofessional, and they did not include the content of 7 and 8, which focuses on how to maintain ongoing effectiveness as a facilitator, and also 8, how to achieve evaluate and achieve impact and demonstrate the impact as a facilitator. So moving on to the next slide, which may be familiar with to you, here we see how complex facilitation is. It starts off with looking at complexity of scope on the vertical axis, all of those functions and activities that are involved in integrated facilitation, and on the horizontal axis it shows you the scope of how many people are involved, starting off with one-to-ones and progressing to groups and teams, organizations which are at the meso level, and then at the macro level, the system focus. For the first time, the research that this was linked with, which I undertook with Angie Titchin, showed how catalytic facilitation was. So in the research with consultant practitioners and aspiring consultant practitioners, we were able to show that it was the facilitation skill set that enabled other people to become more effective. Moving on to the next slide, the question that we want to really answer is, what is it that enables whole systems transformation at the micro, meso and macro levels? So when I'm using the language micro, we're talking about frontline teams, regardless of where they are in the system. Meso are interdependent partners, or the organizations are working together in the system, and the macro level is the system itself. When looking at trying to understand what the principles are for using both the Venus model and integrated facilitation, there are 2 key principles that we need to focus on, and we're going to start with a focus on the micro level. So these 2 key principles is, one, that the most important thing to recognize is that care is provided and experienced in those frontline teams, and that the microsystems is the level that we need to be focusing on in our organizations and in our systems, because the system can be no better than that of our frontline teams. The second thing to remember is that it's the quality of our team leaders in our frontline teams that is a critical factor in enabling effective workplace cultures, and therefore a really important area to prioritize and to focus on. So I'm going to focus now at micro level systems to start off with our first case study. It's the next slide, please, Rebecca. The first case study set out to develop a community of practice with health visitors using action research to make sense of the journeys experienced by them. The purpose was to help health visitors develop their practice development, expertise and skill set. However, it became clear early on that many were working in toxic cultures. And so the priority became to help them use the practice development and facilitation approaches with their teams to help their teams to become more effective, if the potential of health visiting was to be achieved across local populations. So the next slide illustrates one of the tools that we used in the project, which was a culture a collage which tried to capture the essence of the culture that these health visitors were working with. And in this collage, you can see that the health visitor involved was trying to convey what it was like. It was experienced as a war zone with a sinking ship, swimming against the tide, people leaving the sinking ship. So other practice development tools other than the collage was used with participants, and this included a tool called values clarification to identify shared values and purpose in their teams, claims, concerns and issue, a tool that can be used for two reasons. One, to develop an open team culture where everybody's voice is important, but also as a tool to help with the progress of different projects. And third, a tool called emotional touch points, which helps to focus on what matters to people. And in this context of this study, it was the staff working in the teams, the health visitor students who they wanted to retain, as well as the mothers and families themselves. In a moment, we will play two videos illustrating two of the tools, and I'll introduce those when we get to that stage. Before that, though, the next two slides really begin to illustrate what needs to be attended to when embedding shared values and purpose and culture. So on to the next slide, please. Next slide, please. That's great, thank you. So this diagram illustrates the journey of trying to embed a culture change journey, what you have to attend to. So whilst you might use a tool like values clarification to agree values and purpose, that in itself is of no value unless you continue with the other parts of the journey. So the second pillar is about talking about what the values mean, because we make assumptions that we have a common understanding, and it's only talking about our values that we have an understanding or build an understanding. Thirdly, that we then support and challenge each other to live our values, and that's really hard, because to be supportive and enabling but yet bring to the attention of our colleagues when our values are not lived is a hard facilitation process, but one that we need to practice. And lastly, all of those pillars will only come to fruition if we've got structures in our workplace that embed the values. So these structures need to be around how we learn, how we implement our learning, how we evaluate what it is we evaluate, and how we govern in a shared way across our teams. So that's the sort of big picture of the key areas to consider when embedding values in culture change. From the big perspective, it always worries me when you have a new lead in an organization and they want to share the value, they want to change the values, because changing the values means that you never get off the starting block. And so it's really important to look at the longer term in terms of agreed values and how we work with them and implement them. Now the next slide adds a little bit more detail to the sorts of strategies that we need to work with when trying to change the culture as a facilitator and as a leader. So starting at the beginning here left, it is about those collaborative, inclusive, participative principles working together to involve and enable everyone's participation. Then giving and receiving feedback at every level, and then providing the high support and high challenge strategies with feedback that I alluded to help us all live those values that we've agreed with and attend to the purpose that we've agreed. Then creating an open and direct culture that listens and acts on feedback. You know, it's good to rock the boat, but we don't want the boat to sink, in terms of the Nemo analogy. And some of the tools that help us to do that are claims, concerns and issues, and also observations of practice, which I'll say a little bit more about later. Then the last steps are about evaluating progress together using shared decision making and learning, which is implementing, celebrating plus, all those little wins, and then ensuring that each person in the system, in that team, has someone to support and challenge them in sort of mutual learning relationships, such as critical companionships. So moving on now to the next slide, which is where we have two videos, and I'll just say a little bit about these two videos. So these are the health visitors themselves who are participating in this work. The first video models them using claims, concerns and issues in a team meeting to try and create that open culture. And the second one is very short, it's only a minute and a half, and that's modeling the use of emotional touch points with a mother and what matters to her. So we're going to see both videos, one immediately after the other, before then proceeding to the next slide. Thank you, Heather.
Today we are going to use claims, concerns and issues for our meeting. Sarah has agreed to facilitate us. Sarah, would you like feedback for your revalidation portfolio?
Yes, thank you. It'd be great to have some feedback.
Okay. Let's look at the ground rules.
One person to speak at a time. Use the contributor's own words when capturing comments. No discussion until everyone is heard.
Okay, what about the order?
Well, the claims come first, and these are the positive statements, followed by the concerns and issues. And issues are questions that anybody would ask.
Okay, what about the topic?
We're using it to think about how our team is working together to achieve the public health outcomes.
Let's start with the positive statements about our work.
Well, I've just had a really successful session with my health visitor student.
And breastfeeding rates have improved in our locality.
And all our one-year developmental reviews are up to date.
I have just used the emotional touchpoint tool with a new mom. It went well, and she gave good feedback.
So, we've completed the claims part of this exercise. Okay, next. What are our concerns on how we're working together?
I'm really struggling with the new IT system. It's making it really difficult to get my work done.
I don't mind the system.
It's awful.
I'm trying to call the IT help desk. They really help.
Yeah.
Sorry everyone. Can I bring you back to the ground rules? We're not discussing the points at this stage.
Sorry, we got a bit carried away.
Are there any other concerns?
I don't think we provide the right amount of support for our new members of staff and our students. I think everybody is so busy, and now there's revalidation to worry about. I know that's a bit jumbled and I haven't said it very well, but I think it's a worry.
So let's clarify. There are two concerns. Support for students and new staff, and help with revalidation.
Yeah, that's it.
Any other concerns?
Providing for families in need of greater support. We are identifying them, but further support for them is needed.
And hot desking means that sometimes finding somewhere to work can be difficult.
So, we've completed the concerns part of this exercise. Let's move on to issues. What questions are important to ask?
How can I manage my increasing workload?
And how can we deliver the core service to our growing population?
Thanks. Let's celebrate the claims now, before we theme the concerns and issues.
Yeah, there's a lot to celebrate and enjoy.
Looking at the concerns and issues, are there some that can be answered now?
Yes, the question about how we deliver the core service. All staff must prioritize core content and signpost families with difficult needs to other support services.
Thanks for that, that's really clear. Does that answer the question for everyone?
Yes, for now. Hopefully soon we'll be able to offer even more packages of care.
So, looking at the concerns and issues then, there seems to be three themes. 1, support with the new IT system. 2, preceptorship for students and new staff. And 3, support for families needing additional help. Let's now agree what is in our total control, partial control, and what is out of our control.
partial control, I think.
Although I think the support of our new staff and students is totally within our control. The sort of culture that we create will make a big difference as to whether we keep them.
So we all agree? It is important to look at this retention issue in more depth, though.
Yes, but let's look at the first one now, because we have the Director of IT coming tomorrow. Thank you for facilitating the group session for us today, Sarah. How do you feel it went?
I'm pleased I kept to time, and the tool kept me focused.
Would anyone else like to offer some positive feedback to Sarah?
Yes, you brought us back to the task in hand.
You tried to use the words we used.
And I felt valued and listened to.
Thanks for that. It's been a really useful meeting.
We have demonstrated how the Claims, Concerns and Issues tool can be used in our meetings to develop an open culture, which also celebrates achievements.
Marie, thank you for agreeing to give us some feedback on your experience of the health visiting service.
I'm happy to help.
This is a tool called Emotional Touch Points. Reflecting back over the past year with your baby, I wonder, are any of these situations emotional touch points for you?
Well, there was this really emotional time when my daughter was only a couple of weeks old and she wasn't feeding well.
That must have been really worrying. Thinking back, can you remember what emotions you felt then?
Well, it's helpful to look at the words. I was feeling very worried, also happy to have my little baby girl. But with her feeding, it was making me feel really useless.
So you were feeling happy, but the feeding was making you feel useless. Feeding is so important to mothers as well as babies.
Yes, it is. I was feeling quite calm because I knew it was the best thing for my baby girl.
So you were feeling happy and calm. Can you tell me more about the feeling of useless and worried?
And I had to give up breastfeeding and I changed her milk several times, but still she was unsettled. I was worried my daughter was always going to be like this.
And did things get better?
Yes, I got the support I needed.
I wonder how using this emotional touchpoint tool might have helped you then.
Being able to talk about my problems back then would have helped, but seeing these feeling words make it okay to talk about them, feel listened to.
Thank you for that feedback.
Thank you very much for showing those videos. We'll just go back to the slides now, please, Rebecca. Thank you very much. In the context of Finding Nemo, we hope that those videos help you to understand the importance of using things like claims, concerns and issues and emotional touch points as a way of creating a sense of connectedness and belonging for teams with shared values and shared direction, where everybody's voice is listened to and heard and valued. And the second video around emotional touch points just shows how a simple tool can help you to work appreciatively, to build a quick sense of what's going well and what isn't going well, both with citizens and patients, but also with staff. So moving on now in our presentation, we're just going to focus on some case study examples of the meso systems transformation that we were talking about earlier. Go back, please, Rebecca. And the principles that underpin the Venus model. So there are three important principles. The first is developing the staff skill set of the Venus model that enables the workforce at every level to contribute to the speedy achievement of the aspirations of, in this country, the long-term NHS plan, which will enable it to be embedded, sustained with cost-effective use of resources. The second is integrating facilitation expertise to embrace the complexity of different workplaces and enable the workplace and the communities that we serve to be a key resource for learning, developing and improving knowledge translation, inquiry and innovation. And the third is enabling and supporting organisational leadership. So that supportive organisational leadership really helps to strengthen the focus on the development of high quality team leadership and cultures of effectiveness that are good places to work, which support quality and safety outcomes, organisational commitment and staff growth and retention. So now we are going to focus on giving you an example of some work that we have done in a second case study around the safety culture project. So back to you, Kim, and the next slide, please.
Thank you, Carrie. This second case study was about embedding a safety culture across 10 frontline acute hospital teams in 4 large acute hospital trusts by facilitating meso level, that's organisational level facilitators, and working with them as embedded researchers. The project, the next slide, please, Rebecca. The project was called the Squire Project, and that stood for Safety Culture, Quality Improvement, Realist Evaluation. And there were 2 really key findings that we found in the work, and one was to do with the clinical leadership, the quality of that I mentioned before, but that's very much at the microsystems level, and this part of the presentation is focusing on the meso level, the organisational partners level, and that's where we're going to talk a little bit more about the tools that were used to help organisational facilitators support frontline teams by breaking down silos across learning and development, improvement, research and innovation to support transformation. In the next slide, you get a sense of the sorts of tools that were used and how they were used. Next slide, Rebecca, please. Thank you. So on the left, it was about helping the facilitators to use the tools with the frontline teams, and then helping them to use the tools with us and the frontline teams so that we could help to develop the insights about what works and what doesn't work. A further tool that we use, which is not on that slide, we have mentioned values clarification. We haven't mentioned about the use of qualitative 360-degree feedback, or what's called the Paris framework, which is promoting action on research, implementation, health services, how we get the best evidence into practice. And that the other tool that's missing is the observations of practice, which was a very important tool and measure that we used within this project. So as an embedded researcher, then, we were facilitating the facilitators in the organisations who then facilitated the frontline teams. And we worked on trying to embed a safety culture. Observations of practice is really key to helping us understand what the culture is like. Observations of practice involves an insider and an outsider working together to observe for a very short period of time the culture of the workplace. And the insights we gained from this are now included on the next 2 or 3 slides. So the next slide looks at using one of the measures in this project, which was the Texas Safety Culture tool, which the facilitators in the organisations used with the frontline teams. But what was very interesting was using emotional touch points with the facilitators, we found that actually many of the technical tools of quality improvement and measurement tools such as these are not so challenging as the skills required to engage and empower frontline teams. These were the areas that the facilitators found most challenging. So when they used a tool like the Texas tool, having the confidence to know what to do with the findings and how to work with the team to address the feedback from the safety culture tool was key in terms of what patterns the team were implementing and needed to challenge or address or embed. The next slide is in relation to one of the initiatives that was implemented in the Squire project, which was the introduction of safety huddles, which will be familiar to many people. And this slide shows what happened where we observed really good facilitation and leadership practice. So the huddles, what worked was that there was an agreed purpose and structure which was adapted to the specific setting in which it was used. They always happened at a predetermined time. It was staff driven and staff co-created. It was not imposed. There was a focus on staff safety and patient safety, which we would call a holistic approach to safety. And there was multidisciplinary teamwork and a culture of speaking up. So this, it's okay to rock the boat, but not to capsize it approach. And then communication was comprehensive in terms of the preparation to undertake these huddles. And then on the right hand side you see the benefits of why these safety huddles worked, in the benefits to the patient in terms of speeding up decision making. But what was very interesting was where these huddles did not work, and they did not work because the staff participating did not feel a sense of shared purpose. They did not co-create it. They saw the huddles as taking them away from practice rather than prioritizing the problem solving to get the patient's recovery journey moving forward as quickly as possible. The next slide also shows the illustrations from observations of practice. Now, these are positive stories which show how you would recognize that people were living their values within the frontline teams. So observations of practice showed these sorts of illustrations where you have the doctor who requested to be the one to speak to the family following a death because he had been with the family all week, a very person-centered value. The team who shared and listened to each other jointly making decisions, and the occupational therapist who knew the patient most expertly, acted as an advocate for them and said, this patient needs our support now, it cannot wait longer. And then on the right hand side, the doctor on the ward round who praises the registered nurse for detecting the deteriorating condition of the patient, the patient who looks unkempt in A&E and who is unable to take their medications because they can't drink tap water, and the nurse who goes out and gets her own bottle of water from their car. And lastly, the pharmacy technician, not even the pharmacist, the pharmacy technician reviewing medication interactions on the pharmacy chart, highlights to a senior doctor that 2 drugs that he had prescribed were incompatible together, and the doctor responding respectfully, thank you for pointing this out. So those sorts of insights that were observed in this project shows when values are lived. And moving on to the next slide, called the arm's length story. And in this arm's length story, I was working with the head of patient safety in a massive acute trust in a particular ward. And the ward was very well led. And after a period of 1 hour of observations, we were able to provide 22 positive themes of how well the ward team supported and lived their values to support patients and their families. But what was bemusing were that there were all these posters on the ward, and on the poster it said, "You are an arm's length away." Now, because neither I was a stranger to the hospital and the head of patient safety was rather removed, we did not know the significance of these posters and made the assumption that it was to reassure patients that they could get help and families who were visiting that they could get help. So in our feedback, which was immediate at the end of the hour to the ward team, we were able to ask them whether this concept of arm's length had been considered or explored in terms of what it meant, because I had observed an occasion where a patient had been taken to the toilet by a healthcare support worker and left there. So I didn't know whether arm's length meant that you left the patient there and you came back 5 minutes later, whether you agreed to come back 2 minutes later, or what it actually meant. So the feedback we gave was really just about helping them to focus on clarifying what arm's length meant so that everybody had a shared understanding. So I think we're moving on now to the next slides, which Carrie is going to talk about.
Thanks, Kim. So this was a really big project, an evaluation project of what works in terms of embedding safety culture and quality improvement in frontline teams across 4 very large acute trusts in the east of England, working with those frontline teams and MISO facilitators, as Kim said. So the upshot, we apologise for the busyness of the slide, but at the end of the study, we were able to identify what works in terms of strategies to support those senior facilitators who in turn are supporting frontline teams. So what works is having confident transformational leaders who model the way and can live the values and actively listen and engage with staff in an appreciative way that inspire and stimulate improvement and challenge and address the safety issues and barriers that come along. Using a lot of the tools that we've already talked about through claims, concerns and issues, emotional touch points and others, and are able to use a whole variety of improvement approaches, but focusing less on measuring everything and more on measuring what matters to people. But most importantly, they put the service user at the heart for improvement and support frontline teams with local knowledge and skills to build positive relationships, engage teams in co-creating shared meaning, reflection and change, and can integrate those activities with what's already happening to get the best out of people and create a learning and safety culture that systematically embed and use quality improvement tools to ensure everyone's heading in the right direction and are able to celebrate when there's great successes and identify any dissonances in real time. But that welcome feedback from stakeholders and actually act on that. And in turn, that helps staff to feel supported, engaged, enabled and empowered. And those are really important principles for enhancing safety and enabling learning using the workplace as the main resource. So next slide, please. So moving now into macro systems level facilitation and going back to the principles that underpin the Venus model, there are a number of key principles here that we wanted to get across. The first is that whole systems transformation is enabled through authentic, enabling and transformational leadership at all levels of the system. So that's frontline teams, that's MISO facilitators, and that's right the way up to boards and executive teams. Ensuring that the workforce capabilities and capacities are wrapped around the needs of communities and people rather than professions across place, and co-creating services in partnership with providers based on shared values. And the next slide, please. In addition, secondly, we need to be able to grow the people with the integrated skill sets required for facilitation and facilitating that complexity at the macro level of the system. And in the research that we've done to date around clinical systems leadership and the role of the consultant practitioner, there are, go back please, Rebecca, there are 4 key domains, where we would hope to develop the integrated skill set. And they are in strategic and enabling leadership, learning, developing and improving across the system, research and evaluation, preferably through embedded researchers and clinical academic careers, and process consultancy, which helps to embed expertise across the system. And the third is having an integrated approach to learning, development and improvement using governance systems that help to create a sense of shared direction and shared decision making, valuing everybody in the process of decision making, that will support system integrity and demonstrate impact, as well as a collective endeavour to support ongoing quality and safety. Next slide, please. So now we're going to go on to a case study that illustrates macro systems level work. And we've chosen this case study in particular because it's one that was incredibly difficult. And this is a case study of my own, where I was, as a project consultant and external facilitator, commissioned to undertake a big organisational culture assessment and snapshot of a mental health trust by an executive board in the southeast of England. Go to the next slide, please. So in this particular instance, as an external facilitator, the role that I had was to help to support the executive board of this organisation to test out where they were in terms of their culture change journey. And the context of this was that they had embedded a very ambitious transformation strategy, which integrated both a clinical development strategy, an organisational development strategy, and research development and improvements. And I was brought in to identify any areas to celebrate and any areas where there were particular tensions or challenges in terms of the rollout of this ambitious vision and values for the organisation. And in particular, the executive board wanted to know whether frontline staff were living the values and whether their clinical and organisational director leads were able to deliver on that strategy and what the challenges and tensions were. So I set about interviewing heads of service and board members in one-to-one interviews and collectively as a board to find out what they thought was going well. And then I set up a series of workshops with co-facilitators, with frontline staff, and this was a massive organisation, so there were 15 workshops with staff, which enabled us to identify from frontline staff perspective the enablers, barriers and challenges in terms of the culture change journey that the executive board had expected. So this was very much a top-down initiative, if you like. So we used strategies including Johnson's Culture Web to actually map the culture change journey for the whole organisation. With the frontline staff, I was particularly interested in collecting staff stories and in using a workplace culture tool to identify values and beliefs and whether the values of the organisation were actually being experienced and lived out at the front line between frontline staff and service users who were experiencing the service, and what power and control structures were having an influence on frontline staff. And unsurprisingly, as I was going through this journey with my co-facilitators, I discovered that there was a very big disconnect between what the board's vision for the organisation in terms of transformation was with the frontline staff experiences. There had been no authentic consultation with staff and service users in the development of these ambitious transformation strategies, either in the clinical strategy, the organisational development strategy, or in the transformation strategy itself. And there'd been no inclusion of patients, families and service users. So there was a real disconnect with the core strategic priorities that the board felt were important and what frontline staff were experiencing. And of course, the organisational bureaucracy was an indicator overall of the organisational confidence and readiness to change, because whilst the board had all these ambitious plans, frontline staff felt that they weren't being listened to. They didn't have a lot of confidence in terms of their ability to influence the transformation journey, and therefore didn't really feel signed up to the direction that the organisation was taking. And so there was a real disconnect between the values and mission statement of the executive board, that's the values espoused, and then the experience of staff at the front line. So on the one hand, the board mission and values for the whole organisation was talking about how much they valued and listened to staff. And the reality was at the frontline, staff felt as if they had no voice and they weren't listened to, and that they had no real power to change or influence what was happening. So there was a big report that was developed for the executive, which provided a whole series of recommendations. But one of the key recommendations in this was the need to invest in supporting bottom-up transformation and innovation in teams. Next slide, please. And the key message here, really, when we're thinking about both meso and macro level facilitation of complex change, is that in order to facilitate organisational effectiveness, we have to have an eye to 5 key patterns. And this is Plesk's work. And these 5 key patterns link directly to relationships, decision-making, power, conflict, and learning. And it's very important because these five key patterns in culture change strongly influence an organisation's ability to bring about whole systems transformation at scale. So there's a real difference between generating energy for new ideas and innovation versus staff feeling drained by the organisation and bogged down by hierarchy, rather than being enabled to get involved and engaged in shaping decisions that are made, actually having a collective purpose and feeling as though they are curious and eager to learn, and that they have a role in shaping future direction. So this case study in particular was very interesting for me. When I went to present the board report back, it was also interesting in terms of the way in which they, the executive board perhaps wanted me to frame that report. And the key recommendations that were being made, but we made sure that there were a whole series of very clear messages right the way across the organisation, so that the staff that I'd worked with at the front line knew that the key messages that they had ensured that I heard were actually disseminated in formats that would make a difference to the future. And that was a very important part of the work that I did in this particular project. Next slide, please. So there is a real importance here that we think about in the Finding Nemo context, that we enable a supportive environment that allows people to move in the same direction, so that we're not swimming against the tide, and that we're focusing on bringing everyone together to develop flourishing cultures for organisational transformation. And I did actually write a paper with my colleague Alice Webster a number of years ago when we first set up the England Centre for Practice Development, which was our reflections on our journey in terms of building an embedded clinical chair model and taking a large organisation on a culture change journey to enable the whole organisation to flourish from board to ward and back again. So you can read about our experiences in trying to move people from a position of being stuck to a position of being unstuck, and how we used high challenge and high support in a range of different contexts to underpin those transformational journeys. So it's very important that in our current context, with integrated care systems being developed, that we help staff and colleagues become unstuck and are enabled to move on that transformational journey of working independently in what were formerly interdependent organisations into working together across the whole system. Next slide, please. And I'm going to pass you back to Kim.
Thank you, Carrie. So in this last case study, we're picking up the third enabler that we started off the webinar with. And if you remember, the third enabler was about structuring capability frameworks around the person or the citizen rather than around the profession. So this case study was undertaken at the time of the 5-year forward review. And on the next slide, the 5-year forward review for England predated and informed the long-term plan in England. And those aspects in the boxes are what the 5-year forward view aimed to achieve. And on the right-hand side, this was what it meant. So in helping people to understand what it meant, we worked in a workshop to tease out that meaning. So it illustrates the point I mentioned before. It's very easy to assume that what's written has a common understanding. So in trying to take forward this approach, the next slide illustrates the first of 11 service areas that was the focus. The first was focused on services to people with rheumatological conditions. And as I mentioned, it was the first of 11 services that include caring for people with musculoskeletal conditions, eye conditions, cardiac, respiratory, you name it, a lot of medically linked conditions. And so what we did in terms of facilitating this process, it was commissioned by one of 4 local commissioning organisations. And we held a stakeholder workshop with all the stakeholders from across the system, primary care, secondary care, general practice, as well as citizens and service users, to co-create a shared purpose and identified shared values across the system, developing an implementation and impact framework using a values clarification, co-theming together what the themes were that populated that framework. And then following that work, developed what was called a multi-professional capability framework with integrated care pathways. So the capabilities were structured around the person's journey, and the journey started where it was most appropriate for the citizen, whether that was in the home or within general practice. Then we then developed the referral criteria between the key providers of this service, and those providers were seen as a general practice setting where most people would be accessing health and social care initially, the specialist team with all the expertise in caring for people with rheumatology, and this was led by a nurse consultant, and thirdly the secondary care medical consultant led aspect for the most complicated and complex conditions that were not responding to the standard evidence-based treatments. And then we put in the nurse consultant then evaluated her role as a systems leader, and she moved from an acute setting to a general practice setting where a small case study was undertaken using what had been developed. And what we found was the potential was enormous, because the impact on the patient of this was that we showed that there was increased self-management on the part of the patient. There was a reduction in drug use, increased mobility so that patients actually could leave their homes, and they hadn't for months and years, and much greater family support. The impact on the general practitioners were that they absolutely loved it. It increased the educational support to them and their patients, so much so that they were willing to take on more work, which is quite rare with general practitioners, in terms of blood monitoring. Also, there was an impact on the rheumatologists in secondary care. Now, it's fair to say that they provided peer review and support, but they were cautious. They were cautious because they did not appreciate what advanced practitioners and multi-professional consultant practitioners in all our professions can actually do and achieve. So the implications of this work were for how we activate expertise in our patients and citizens, how we develop e-consultancy services, and how we upskill our community services and our general practices. The potential was enormous, but the system architecture did not exist for saving Nemo, because many of the stakeholders struggled with the barriers that they perceived, the waves that prevented them moving forward. The architecture was not there, the funding was not there, some of which these things are now being addressed. So I take solace from the next slide and Richard Branson, because I think this is an important point. You know, if your dreams don't scare you, they are too small. And these were dreams that are now becoming to fruition. And it is the facilitation skill set that enabled this to be achieved. So now I'm going to ask Carrie to emphasize some of the key learning, the key challenges from this webinar.
Thank you. Next slide, please, Rebecca. We're just coming to the end now. And these are observations from a whole body of work that we've been doing over a number of years now. So the key challenges and grey areas for facilitation that we think need further research and development. On the left-hand side, we can see the challenges are growing the integrated facilitation expertise across organisations and systems at pace. Is a challenge for all integrated care systems right now, and facilitating citizens to lead the agenda, because they should not be an afterthought, they should be driving our plans for the future, but also focusing on frontline teams that really need our help, and developing shared governance for learning and improvements, and mechanisms for continuous system-wide learning, so that we're constantly building on celebrating what we've learned, identifying what hasn't worked and why it hasn't worked, because that's equally as important, and then cascading that learning across the wider system. And really challenging, breaking down those professional silos so that we stop thinking about just a uniprofessional approach to transformation, and that we think about how we use facilitation for learning, development, innovation and improvement, and research, using the workplace as the main resource. So these 4 bullet points we think are areas for future research and development. We want to test the Venus programme theory across the systems at the 3 levels, so that we know whether those principles are the right principles. We think we need to evaluate the impact and cost effectiveness of integrated transformation teams, supporting frontline teams with bottom-up change. Develop impact indicators and case studies for implementation of the international facilitation standards that we talked about, and explore with universities whether they're interested in academic accreditation of those international facilitation standards. So thank you very much for your time. On the next slide, all of the references are available to you. And the key message from today is that together we can help people to swim in the same direction and have more impact if we do that together, connecting all those different parts of the system. Kim, I'd just like to invite you to make any final comments that you'd like to make.
Thank you, because I know we're really tight on time, and I'd like us to say a little bit about the next webinar, if possible, please.
Yes, thank you, Sally. Do you want to come and introduce the next one?
Sure. Thank you very much, Kim and Carrie. Very, very detailed oversight there of the complexities of big organizational change that means something to people. And there was a couple of questions there, but perhaps now is not the time. Yes, so the next webinar will be looking at workplace well-being, and we have some key colleagues that we're working with here at UEA that will be presenting their research and their interest and understanding, that I hope will be useful to all of you who are carrying the load, as it were, of all of this work that we're trying to achieve to make a difference to people's lives. So thank you, everyone. Thank you for the little conversation that was going on in the chat there. And thank you again to Kim and Carrie for sharing all of the work that you've achieved to date. And as Carrie and Kim said, let us know if you want any help with what you're tackling with in your organisation. We're always here to have a critical conversation with you about any of this work. So thank you all, and hopefully see you on the 6th of July for a workplace wellbeing discussion. Thank you all.
Thanks, folks. Please feel free to email questions to us, and the film will be available, recording will be available on YouTube shortly.
Thank you. Thank you all.
Bye for now.